and welcome to everybody. I hope you're all keeping safe in this awful time of COVID-19. At least in England we've got some good weather, it's just we're not allowed out in it, but I hope it's not too bad where you are. I hope you can all hear me. If not, please do send messages to Anya or in the chat. I'll just share the presentation now, so hopefully you can all now see the presentation. So what we're going to talk about, obviously, is HIFU or echotherapy of the varicose veins using the Sonovein technique. And this webinar is sponsored by Theraclion, who obviously have been working closely for this work. So in the past, varicose vein treatments have always been treated with open surgery up until the end of the 1990s. The basic 1998 endovenous surgery started appearing. We introduced it into the UK in 1999. And for a long time, the TT, or the thermal ablation, has been the technique that most people have regarded as the optimal way of treating varicose veins. And indeed, NICE, the American Venous Forum, and the European consensus documents all say it is now the thermal ablation of the truncal venous reflux is the optimal or first-line treatment. A lot of companies and a lot of doctors have been trying to take this on to being a non-thermal endovenous technique. Therefore, the technique really is still very similar, an endovenous technique inside the veins, but just trying to remove the tumescence. However, what Sonovein gives us the opportunity to do is take a turn away from that and actually come away from anything being introduced into the veins at all, to come outside of the body and to become totally non-invasive in treatment. I think that this will be as big a change as stripping was hidden away by endovenous work. I think this will also take over from endovenous work, and this will be as big a change as we saw from stripping to endovenous work. And I think we'll see the same change now to non-invasive HIFU and maybe other technologies, but HIFU without doubt is the thing that we're going to be seeing for a long time. This is a paper I've recently written with my opinions in it in Current Medical Research and Opinion. If any of you would like a copy of this paper, please just email me after the presentation or contact me and I'll send you a PDF of this. But as I've said in it, I truly believe this is the next way forward for varicose vein treatments. So what is HIFU, or what is echotherapy? This is the machine we're using, which is the first generation of vein treatments from Sonovein. It's high intensity focused ultrasound. Initially, it's been used for thyroid nodules, breast lumps, prostate. In different forms, it's also been used, HIFU is used for other diseases, and currently it's being used across the skull, and people are using it for ablating certain areas of the brain, such as in Parkinson's. However, we're just going to talk about the use of HIFU using the Sonovein echotherapy machine in varicose veins. So HIFU has two main ultrasound parts, certainly in the echotherapy. The first is we have to see where we're going, and this is a 2D grayscale ultrasound imaging, just like any normal real-time grayscale ultrasound imaging. It also does have color flow on it, which is very useful for when we want to see if the vein or artery is still flowing, and to check which is which if our anatomy is slightly blurred. But this is very useful as just the grayscale. Surrounding this is the ultrasound dome, and being a dome, when this vibrates at ultrasound levels, it causes a cone of energy that can be passed through the skin and at a focused level will cause heat. So the absorption of ultrasound is this process of the conversion of the vibrational energy. Remember, sound is vibration, and at certain frequencies passed into tissue and focused, it causes heat at a specific point. In biological soft tissues, there are the usual absorption coefficients, and that changes. There's a lot of physics around. If you're interested in this, there's a reference here you can see, but there's a lot of different papers you could look at. Now, what we use is we use a local anesthetic around the vein to try, because obviously there's going to be some discomfort in some patients if you're heating tissue, and we must degas that. So any gas that is formed is from the ablated tissue, and this is important when we're looking at the 2D ultrasound. So when we have the echotherapy imaging, first of all, we put the machine onto the leg, we see the great saphenous vein, and here on the right hand side we can see the collapsed great saphenous vein with a small amount of local anaesthetic around it, much less than we'd use for tumescence. We can see the skin at the top here, and we can see the standoff. There's a balloon that lies between the end, the nozzle of the HIFU machine and the skin, so that it's full of fluid, and it means there's no air, which would of course absorb the ultrasound. So the focused ultrasound can come straight down onto this target vein. Once we've targeted it, we then fire the dome, or we'd fire the focused ultrasound, and as you can see on the left hand side, there's a focusing in this three-dimensional cone to one point, and that point is approximately 5 millimeters tall and about 3.5 to 3.6 millimeters across. You know you're doing the right job when you see the pattern on the right hand side, and this white X, the X we see in the middle here, this is the reflection of the gas that is being formed in the tissue that's being ablated. On either side there's the dark areas, and this shows that there's no gas and therefore no reflection of ultrasound in the areas which have got the local anaesthetic in them. Immediately after the treatment, which is about 8 seconds long, you can see that this great saphenous vein here is completely ablated. You can see how lovely it is to see all these little gas bubbles, and that shows that we've reached the temperature that we require to ablate that vein. Unlike laser or unlike radio frequency, this is not causing charcoal and at very extremely high temperatures. These temperatures are in the range of about 70 to 90 degrees centigrade, so full tissue ablation, which is exactly what we want without actually having massive tissue disruption. This is the setup we have in our room at the moment. It's actually in an outpatient room, not in the operating theatre. I'm only wearing operating clothes because this is what I normally wear day to day, so I don't get any ultrasound gel on my normal clothes, but there's no reason I shouldn't be wearing just a suit with just a small apron on. I'm wearing gloves purely and simply because I'm going to give injections, and because there's a little bit of ultrasound gel here. So again, very soon I'll produce proper photographs of me wearing my normal clothes doing this. The patient has got straight up onto this couch here. The ultrasound gel is placed onto the vein. We then position the ultrasound head using two handles here, and there's a robotic arm where we can position exactly where we want this ultrasound head to be, and we can then scan up and down the vein as we want to. And I think you can probably just see on the right hand side of the screen there's the V, which is where we're actually making sure that we're aiming directly on, and that heating point, the focus of the ultrasound, is on the vein that we want to treat. The next is going to be a video. It starts straight away, so you'll see how this works in real life, and you'll see one pulse. So this is me at the pulse with firing. You can see that pattern forming on the screen, and you can see the small saphenous vein on the right hand side being ablated there. I'll just pause the video so we can just go back and have a look at it, which is something I can't usually do at conferences, which is nice. So you see I'm just here. I'm actually concentrating not on the patient, which is very strange for most surgeons. We're looking at the level of the vein here. These are about 3.5 millimeters apart, so 3 of these is 1 centimeter of vein. We have the aiming on the right hand side. We can see exactly where the vein is, and we have the standoff. You can see there's a centimeter or 2 above the skin, so that's how we can change. By changing that balloon depth there is how we can focus the ultrasound. As soon as I'm ready, it's going to fire, and we're going to start the video again so you can hear. Oops, sorry. We're just going to start the video so you can hear the firing. That's it going there, and as the camera pans across, you can see what the patient's actually having there, which is 8 seconds of HIFU energy passed into the small saphenous vein, and you can see the instant fizzing of the vein at the end of the video. So the technique: we use a clinical room. It's not an operating theatre. It's only clean. It's not sterile. We mark the veins we wish to treat. We've found that we speed things up tremendously if we mark them first of all, so the patient comes in pre-marked. You can do this with the Sonovein machine, but if you're going to do this commercially, obviously you don't want to waste time with the treatment technique, so it's easier to use a small ultrasound next door, mark the vein, as the patient comes in, get straight on with treatment. We position the Echotherapy robot arm exactly on the vein and run it up and down, so we show the robot exactly which course the actual vein is running in, and we just keep on moving it around using the 2 little handles until we're exactly perpendicular to the vein, so it runs up and down it. We fix the position, And once we've fixed the position, so the machine knows where it is, we have a little positional laser. This means that if there's anything that moves, the machine knows where the end of the ultrasound probe is. So there's a very important little point, it's just a little positional laser, which anyone who knows anything about industrial robots will know about. Once you've identified the target vein yourself, then we just, if the patient needs it, we can put a little bit of local anaesthetic around the target vein. We tend to do it in all of our patients at the moment, although Professor Obermeyer has found that about half of his patients he doesn't use it at the moment. I think as we get better and better at doing this, the amount of local anaesthetic needed will become less and less. At the moment, we're taking things very gently because obviously we don't want bad reports in the early stages. We use very, very low volumes and we use a very, very fine needle. And one of the things that's interesting is, although patients often find local anaesthetic under the skin tender and tumescence tender, when we're doing this sort of local anaesthetic, most patients can't feel it at all. And the reasons for that is when you have the Sonovein machine on the skin, it's actually cooling the skin itself and providing a bit of pressure. We're using a very, very small needle, either an orange or a blue needle, so a 25 or a 27 gauge needle, putting it in quite deeply, sort of compared to normal cutaneous work. And so therefore, when we're injecting it, it's not stretching the skin, and most pain receptors are completely and utterly in a different area. They're usually up just under the skin itself. So most patients don't even feel the local anaesthetic going in, and you mustn't confuse this with tumescence, as I almost just did there. We then treat the vein. You've just seen how that happens. It's an 8-second treatment at the moment, and we're treating about a third of a centimetre every time. Move down to the next third of a centimetre, fire it, and repeat, and just start walking down the vein. This is what it looks like beforehand, and this is what it looks like straight afterwards. And really, it's very satisfying because you can see the treatment immediately, and you know you've had a good treatment. With incompetent perforating veins, this is what an incompetent perforating vein looks like pre. Above is the grey scale. Below, we can see the reflux on colour flow. And then what we do is we fire it straight away. The immediate post-operative, you can see there's no flow at all, and you can see that it's already, you don't have quite so much echogenicity in there. 1 week later and 6 weeks later, you can see how it's just being taken over by inflammation and still no recurrence. So what's our early experience? The photograph on the right is just me positioning it on a small saphenous vein. So we started in May 2019, so just about a year ago, 11 months. The learning curve is 15 procedures, and it really does take those 15 procedures to get your eye in and to get used to doing it yourself. We started with incompetent perforating veins. I think I would have found life a lot easier if I'd started with great saphenous veins. I thought I was making my life easier by starting with small veins, but in fact, although this can treat any vein you want to treat, a bigger target is easier to start with. We then moved on to truncal veins, and it's been a huge relief. I mean, we're getting some beautiful results now with the great saphenous vein in particular. It's really lovely. So what's our early experience? We've had 46 legs in 38 patients. If it hadn't been for COVID, we would now be probably up into the 60s or 70s, but unfortunately, we've not been able to go to the clinic now for 6 weeks. There are 29 females, 9 males. The mean age is exactly as you'd expect in a venous practice, especially a private practice, between 30 and 80 with a mean of 57. One patient withdrew after 2 pulses. This was actually only the second patient we treated, and she had really hyped herself up. And even during the consenting process, she said, what happens if I have a panic attack? What happens if I can't go through with it? So she had already really set herself up to fail. So unfortunately, as soon as she started throwing a panic attack, we just said, you know, it's just not going to be worth talking her through it. She's subsequently been very upset and wants to come back and have it, but we won't let her because there's just no point in getting to that sort of scenario. All of the patients that I've treated are between C2 and C4. We haven't treated leg ulcers yet, although we have some coming up. These are the numbers we've treated, 90 incompetent perforating veins. Now we've done 15 great saphenous veins, right up to 14 millimeters of diameter, 3 small saphenous veins, 4 anterior accessory saphenous veins, and 1 set of neovascular tissue. The results at 6 months. So these are not the early results. This is the early results of those that have gone for the whole 6 months. Of the truncal veins, the very first one we tried was a very small anterior accessory venous vein, and I wasn't really doing it very well. It failed to close immediately. It wasn't a good case, but it was my first attempt. Since then, everything that we've tried to close has closed and remained closed at 6 months. With incompetent perforating veins, 27 have now gone through the 6 months. We've had 3 failures, although interestingly, those have all become competent. And we've had 21 that are completely closed, which is an 89% success rate at 1 week and 6 months. I've already told you about it's the 5th patient. The 1 refusal, that was a panic attack patient. The 1 anterior accessory venous vein failed. I've told you both about them already. Now, you must remember, just like all patients who are having surgery, any inflammation is going to cause some discomfort, lumps and bumps. If you ever have any painless surgical treatment, it means that you're not actually going to cause any tissue disruption because you won't be getting inflammation. All of the ones we've had so far have settled by 4 weeks, and patients have sort of just been a bit shocked because they seem to think that non-invasive means you're not doing anything. But of course, if you are destroying veins, you will feel veins that are near the surface as they go through the inflammatory resolution. 2 patients have had sural neuropraxia. These were on small saphenous veins, and 1 has lasted more than 4 weeks, and we're just following her up at the moment. We have had 1 tiny deep vein thrombosis. It was a single element of a posterior tibial vein only, and it was clinically irrelevant. There obviously no treatment. The patient was walking normally, as they all do straight afterwards. So what are the strategies? And this is where the research is most interesting for us at the moment on the clinical side. I'm sure the company has their own research to keep on optimizing that side of it, but on how do we treat the patients at the moment? It comes down to, do you offer them combined treatment where you use echotherapy to close the areas of reflux, and then ultrasound guided foam sclerotherapy all in one session? I suppose you could do phlebectomies, but from my point of view, I don't see why you would do phlebectomies if you're offering a non-invasive treatment. Or do you separate it? Do you do echotherapy in the first session, and then 8 weeks later, if they needed, ultrasound foam sclerotherapy? Obviously, we know that from some of the early work in when we did endovenous ablation, and also with Chiva type works, if you can get a lot of the reflux going, some people don't actually need the phlebectomies at all. So the question is this second one, separating them into 2 sessions, an optimal way? And certainly I'm becoming much more happy with going with the second route here. Certainly one of my own staff had this done, and she had really quite pronounced varicose veins. She had 3 perforators and a large great venous vein, and the great venous vein was only 7 centimeters before it became extrafascial. So I closed the top 7 centimeters and the 3 perforators and left her for 8 weeks, and the veins shriveled away, but they were still prominent. And so I then did foam sclerotherapy, and she's now thrilled with the results. And I think this might be an optimal way of treating patients. So in summary, our early results, very good results. All of the veins that were closing are closing very well at the moment, with the exceptions I've told you about. Very high patient satisfaction, people back to work the same day. We've actually had one of our nurses had this done in the morning. She had both great venous veins treated, and then she was back to work in the afternoon. It does take some time at the moment, but there are quite a few shortcuts you can take with the current machine. I'm absolutely sure that Sonovein Theraclion will be working towards speeding up treatments as we go forwards and working out ways and strategies to do that. In the future, whether we do HIFU and foam in the same session or separate them, which might save having to do foam in some people, that's going to be the question at the moment. So in conclusion, the HIFU echotherapy appears to be safe and effective. That's what we always say when we're talking about something new, but this really is not only that, but I think it is also going to be disruptive as a technology, because this doesn't even need to be done by a doctor. I think we can have our vascular technologists doing the actual procedures with us poking our heads in as we see fit. Thank you very much.